From Microbe TV, this is Infectious Disease Puscast, episode 55, recorded on May 27th, 2024 at 8 a.m. Memorial Day morning. Hello, everyone. I'm Daniel Griffin, and joining me today is Sara Dong.
Hi, everyone. I'm Sara. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. Thank you for moving the recording. I just got back from ESPID, which was in Copenhagen this year, and it's my first time to a European conference, and I was able to take some vacation sightseeing with it, so that was really fun. How are things with you, Daniel?
They're good. I'm a little jealous because I love Denmark, right? I was just up there with Barnaby recently, but no, not to Copenhagen. So how was it? The Danes are
It
just
was
great,
great.
right?
Yeah, something I didn't really realize is how long it's daylight. The sun will come up at like 4, it probably was 4, and then it would still be light out till almost like 10 p.m. So it's really nice, although I think if it's still daylight out, you kind of want to be outside because the weather's so nice. And I think I may be a little tired, not from the time change, but just from being out and about and doing things for so long.
So
That's a
many
good
waking
problem.
hours.
Yeah. So that was really fun. All right. Well, Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right. Well, let's get right into viral. And remember to listen to TWIV this week in virology. So as some of our listeners may not also be listening to TWIV clinical updates, let me share the MMWR early release outbreak of highly pathogenic avian influenza A, H5N1, viruses in U.S. dairy cattle and detection of 2 human cases, United States, 2024. And here we read that on April 1st, 2024, the Texas Department of State Health Services reported that a dairy farm worker had tested positive for highly pathogenic avian influenza A, H5N1 virus after exposure to presumably infected dairy cattle. CDC confirmed these laboratory findings. The patient only experienced conjunctivitis without other signs or symptoms, was instructed to isolate, was treated with oseltamivir, and recovered. No illness was identified among the patient's household members, all of whom received oseltamivir post-exposure prophylaxis. Just picturing this gentleman being yelled at, "Stop rubbing your eyes." Anyway, 1 week earlier, the U.S. Department of Agriculture had reported a multi-state outbreak of the H5N1 viruses in dairy cows. The viruses were also detected in barn cats, birds, and other animals, so a raccoon, a couple of opossums that lived in and around human habitations and that died on affected farms. Genetic sequencing of the virus from infected cattle, and the farm worker identified clade 2.3.4.4b. That's the one that we're worried about. This clade has been detected in U.S. wild birds, commercial poultry, backyard flax, and other animals since January 2024. On May 22nd, 2024, the Michigan Department of Health and Human Services reported a case in a dairy farm worker on a farm confirmed to have the H5N1 virus in cattle. This person was enrolled in an active text-based monitoring program and reported only eye symptoms. The investigation into the second case is ongoing, but these 2 cases are the first known instances of presumed cow-to-human spread of an avian influenza A virus. Now, as of May 22nd, approximately 350 farm workers with exposure to dairy cattle or infected raw cow's milk have been monitored. Pasteurization inactivates the H5N1 viruses, and the commercial milk supply is safe for consumption. Importantly, the risk to the public may change based on whether H5N1 viruses acquire genetic changes that increase their transmissibility to and among humans, which could increase the risk of an influenza pandemic. So we keep deep diving on the This Week in Virology clinical updates. So for more, including my wonderful quotation, yes, honey, you can get this in your eye, please go to the deep dive. I also wanted to share the article, The Importance of Including Long COVID Outcomes When Developing Novel Treatments for Acute COVID-19, published in JID, suggesting here that long COVID outcomes should be included in studying treatments for acute COVID for 7 reasons. Now, the authors, they refer to these as the 7 compelling reasons to include long COVID measurements. So, 1, long COVID is not rare. 2, long COVID is debilitating to individuals and has a high societal cost. 3, those at high risk of severe COVID-19 are also at higher risk of developing long COVID. 4, treatments for acute COVID-19 may reduce the risk of long COVID. 5, measures exist to track long COVID. 6, long COVID considerations are potentially important for acute COVID-19 treatment decision making. And 7, deaths and hospitalizations due to COVID-19 are increasingly rare, creating an opportunity for other important clinical endpoints to be considered.
All right. And I took an article from JID, which I realize I less commonly pull ones from that journal, but it is entitled Reactivation of a Transplant Recipient's Inherited Human Herpesvirus 6 and Implications to the Graft. This reports a case of reactivation of a pediatric recipient's inherited chromosomally integrated HHV6 and subsequent infection of their deceased donor split liver transplant. And so I suspect some of the listeners know, but understanding the clinical implications of inherited chromosomally integrated HHV6 is quite challenging. In solid organ and stem cell transplantation, most infections are going to be reactivation of previous postnatally acquired infection with HHV6B. Donor cells can also be an additional source of HHV6 as well. So grafts, both of hematopoietic cells and solid organ grafts may have latent virus, which could be episomal or chromosomally integrated. And we can't really tell what type it is. So is there active replicating virus or more silent chromosomally integrated HHV6, and whether it's from the donor or the recipient when we just check a clinical PCR when that patient is hospitalized. So the authors use some multiple virologic techniques to show HHV6B transmission from the recipient's chromosomally integrated HHV6 to donor cells in the allograft. So they actually showed that HHV6B was in the donor liver before the implant at low levels, and then rose and was persistently elevated in the higher over 6 log levels in the graft after transplant. And they found that the HHV6B sequences from the liver tissue before and at multiple time points after the transplant, they collected those and then showed that the sequences pre-transplant were distinct from the recipients, but then afterwards, when it remained elevated, those sequences matched the recipient's pattern. So active replication here. And they showed a couple other things: positive viral mRNAs, antigen staining and tissue sections, upregulation of cell surface molecules, transcription factors, cytokines. You can obviously read it in detail in the paper. But all of this info would potentially support active infection in the graft originating from the recipient's chromosomally integrated HHV6B. I think big picture, how much the HHV6 contributed to all of the biliary complications in the patient case presented is a little hard to tease apart. The patient had other complications like biliary leakage, necrotic liver lesions, cholangitis. They did start ganciclovir and later Valgan in the example case, but the patient continued to do poorly. And so the authors pointed to the importance of pre-transplant screening for chromosomally integrated HHV6, I added a 6, and then monitoring for reactivation after. In this case, the patient had a second transplant and received antivirals in the setting of that new transplant. I don't know that it's clear that routine screening for HHV6 in transplant donors and recipients is necessarily ready for like prime time, high value ad. But even if we can't sort of specifically link everything together with this one case, I thought it was a really amazing look at how HHV6 reactivates, what that could look like. And for me as a non-virologist, learning about the different testing methods that they had to try to really distinguish between recipient and donor was really interesting.
All right. Well, don't sell yourself short, Sarah. You are an expert in virology as a pediatric and adult ID specialist.
So
We will move into bacterial, where you're also an expert. And be sure to listen to This Week in Micro. The article, Role of Routine Suppressive Antibiotic Therapy After DARE for Acute Periprosthetic Joint Infections, published in Open Forum Infectious Disease. Almost made it in the last recording. For background, they tell us debridement, antibiotics, irrigation, and implant retention, that's that crazy DARE four-letter acronym, is the first-line management strategy for acute periprosthetic joint infections. But what about a little bit of suppressive antibiotic therapy? So, suppressive antibiotic therapy, SAT, after DARE is proposed to improve outcomes, yet its efficacy remains under scrutiny. So these are the results of a multi-center retrospective study in patients with acute PJI of the hip or knee treated with DARE in centers from Europe and the USA. Let's start with the conclusion, and then we can discuss a little bit about whether we are dealing with one of those type 2 errors where we fail to show something is true and then jump to thinking it must certainly be false. They include 510 patients with 66 treatment failures, with a median follow-up of 801 days. They report that they did not find a statistically significant association between SAT, suppressive antimicrobial therapy, and treatment failure. Hazard ratio 1.37, p-value 0.27. Subgroup analyses for joint, country cohort, and type of infection, early or late, did not show benefit for suppressive antimicrobial therapy. Secondary analysis of country cohorts showed a trend toward benefit for the USA cohort, hazard ratio 0.36, so maybe about a 64% reduction, but the p-value was only 0.09, not hitting that magic 0.05. It's about a 9% chance that this really wasn't actually true. But the US also had the highest risk of treatment failure. I do recommend reading the discussion where they address the limitations and tell us that their subgroup analysis suggested that there may be some high-risk features such as Staph aureus infection, chronic kidney disease, and others that may help sort out who might actually benefit from that suppressive antimicrobial therapy. They do recommend further studies with the non-conclusive nature of this one.
I just want to say there's lots of lightning and thunder going on outside, and I'm hoping that at one point it'll just be a very well-timed thunder.
I like it.
I have to make a dramatic point.
Yeah.
It's very... So in JAMA Internal Medicine, I pulled a paper, Mortality of Patients with Sepsis, administered piperacillin-tazobactam, I'll probably say pip/tazo, versus cefepime. The authors from the University of Michigan posed the question of whether the use of a combo of vanc-pip/tazo is associated with increased mortality risk compared with vanc-cefepime in patients with sepsis without a specific indication for anti-anaerobic antibiotics. So things like necrotizing infection, intra-abdominal infection, head and neck infections. They had an instrumental variable analysis using a 15-month pip/tazo shortage as a natural experiment in a cohort of 7,569 patients with undifferentiated sepsis admitted through the ED. So this was a retrospective cohort study of EHR data. 4,523 were treated with vanc-pip/tazo, and then a little over 3,000 were treated with the vanc-cefepime combo. They found that treatment with vanc-pip/tazo was associated with a higher 90-day all-cause mortality than vanc-cefepime, suggesting that patients with sepsis without anti-anaerobic coverage needs may have greater mortality risk with vanc-cefepime. than with vancomycin. Pip/tazo was associated with the absolute mortality increase of 5% at 90 days, so 22.5% versus 17.5%. That group also had 2.1 fewer organ failure-free days, a little over 1 fewer vent-free days, and about 1.5 fewer vasopressor-free days. They also took a look at really exposure to any anti-anaerobic antibiotic, including metronidazole, and found that that was associated with worse outcomes as well. People may remember that we talked about the relatively recently published ACORN study that pointed to no significant difference in mortality across groups. So some differences there. ACORN looked at 14-day mortality, whereas the primary analysis in this paper was 90 days. The authors actually did analyze their outcomes at 14 days and found no significant difference between the groups, which they felt indicated that this time point would be premature for detecting mortality differences. The authors also pointed to ACORN's crossover methods and lack of adjustment for other anti-anaerobic antibiotics like metronidazole, as well as in their group a smaller proportion of patients with sepsis and critical illness. Ultimately, the ACORN trial actually, it asked a different question. That was their conclusion, was more about AKI, but I think since that's the most recent study in people's minds, that you may be sort of comparing and contrasting a bit. So, in sepsis, most patients probably don't need anaerobic coverage. So if they don't need it, then why give it? I think it's a bigger question. I'm very pro vancomycin, which is my bias. But I think the other take home for this is, I think they say never let a good drug shortage go to waste. So these authors took advantage and asked a clinical question that they've been wondering about.
All right. The article, Second Times the Charm, Assessing the Sensitivity and Yield of Inpatient Diagnostic Algorithms for Pulmonary Tuberculosis in a Low Prevalence Setting, published in Open Forum Infectious Disease. We read in the background of the abstract that among persons with suspected tuberculosis, CDC guidelines recommend collecting 3 respiratory specimens 8 to 24 hours apart for acid-fast bacilli smear and culture, in addition to 1 nucleic acid amplification test. However, data supporting this approach are limited. So the objective here was to estimate the performance of 1, 2, or 3 AFB smears, plus or minus the NAT, the nucleic acid amplification test, to detect pulmonary tuberculosis in a low prevalence setting. So these are the results of a retrospective study in 8 Massachusetts acute care facilities. In this study, they found that no third AFB smears were positive, sort of consistent with that 1 or 2% teaching, following 2 initial negative smears. 36 of 52 smear negative cases had NAT performed, leading to 23 additional diagnoses. So overall, sensitivity to detect tuberculosis prior to culture positivity was higher in any strategy involving 1 or 2 of those NATs, even without AFB smears, compared with 3 smears alone. So you're talking about a 74 to 79% sensitivity just doing the NAT versus 60% with those 3 smears. So DARE, and that's like little ARE as opposed to the other dare I suggest that it is time to update the guidance.
All right. And then I pulled a paper from CID, Social Factors Associated with Congenital Syphilis in Missouri. Here, authors identified 131 mother-infant dyads with potential congenital syphilis in a large Missouri hospital system and compared social determinants of health faced by the dyads with or without congenital syphilis outcomes. 74 or 56% of the group of the dyads had congenital syphilis outcomes, and then 56 or 43% were, you'll hear me say, non-congenital syphilis outcomes. So these were extracted from an STI screening database. The adverse social determinants of health were common and dyads impacted by congenital syphilis. And you can see in their visual abstract, which I'll point out, when comparing the cohorts, those with congenital syphilis outcomes had inadequate prenatal care 60% of the time versus 31%, which was the strongest correlate with congenital syphilis outcomes. Substance use was common, 54% versus 27%, and housing instability as well, 34% versus 14% in the non-congenital syphilis outcomes dyad group. I thought another interesting takeaway was that CPS involvement at delivery was common in all dyads and more common in those who had congenital syphilis outcomes, so 61% versus 34%. CPS custody was taken at delivery in 30% of dyads with congenital syphilis outcomes compared to 5%. So, high rates of substance use, housing instability, justice system interactions, these are all just pointing to the opportunity to think about and provide syndemic care. So the importance of collaborating with other resources, whether that is substance use risk mitigation, access to housing and shelters, and so on. So obviously, I think we all sort of know this, but this re-emphasizes how any congenital syphilis prevention efforts really need outreach to really cover all of these different aspects of their life. And I'll just end with the quote from the paper, which is not necessarily from the paper. I think it's from like any ID doctor. But every encounter with the healthcare system is an opportunity for syphilis testing.
All right. I read with great interest the article Impact of Oral Vancomycin Treatment Duration on Rate of C. difficile, Clostridioides difficile recurrence in patients requiring concurrent systemic antibiotics. This comes up all the time. A person's on antibiotics for one thing and oral vanco for the C. diff. And how long do I continue the C. diff treatment after I finish those antibiotics? Well, here the authors perform a retrospective cohort study where they evaluated adult hospitalized patients with an initial episode of CDI, C. diff infection, who were treated with vancomycin and who received overlapping systemic antibiotics for greater than 72 hours. Outcomes of interest included the CDI recurrence, isolation of vancomycin-resistant enterococcus. Among the 218 patients included, 36% received a standard duration and 64% received a prolonged duration of treatment for a median of 13 days, so sort of 11 to 14, and 20 days, 16 to 26, respectively. Patients who received a prolonged duration had a longer median duration of systemic antibiotic overlap with vancomycin, and significantly more carbapenem use and infectious disease consultation. Recurrence at 8 weeks, 12% standard, 8% prolonged. Recurrence at 6 months, 15% standard, 10% prolonged. And VRE isolation, 3% standard versus 9% prolonged. Discontinuation of vancomycin prior to completion of antibiotics was an independent predictor of 8-week recurrence, and that was an odds ratio of 4.8, so almost 5 times as likely. Good confidence intervals there. We could consider more trials with a bigger sample to get a more statistically significant difference for all the subgroup analysis here, but seems to support the current approach with us ID docs extending the oral vanco past completion of those other antibiotics.
And to wrap up our bacterial section, we always have to mention these: association between infectious diseases consultation and mortality in hospitalized patients with gram-negative bloodstream infection, a retrospective population-wide cohort study, which was published in CID. Authors found that early ID consultation was associated with reduced mortality in patients with gram-negative bloodstream infection. The 30-day mortality hazard ratio was 0.82, which translated to a number needed to treat of 27, or absolute risk reduction of 3.8%. The lower all-cause mortality remained when analyzing at 90 days as well. Just for a little glimpse on what they did, they found of 30,000 or so patients with gram-negative bacteremia across 53 Ontario hospitals. About 11,000 or 37% received an ID consult. The proportion of patients receiving an ID consult varied a lot between the hospitals. I think if you were going to look at the paper, I highly recommend you check out Figure 2, which I think is really interesting. It shows the variation in ID consult proportion sort of based on the sites, as well as the timing of when ID was called or consulted. It does seem like there was a particular advantage in those who had multi-drug resistant organisms, non-Enterobacteriales gram-negatives, earlier consultation, and a couple other features. So, I'm sure there's people who are listening to this and are like, well, I don't want to be consulted on every gram-negative bacteremia. But I think it sort of reinforces what we probably already think, which is those patients who have resistant bugs or more complicated one blood culture that has an Enterobacteriales. Those are the ones that I think we probably add value. So we'll keep an eye on and keep grabbing these articles when they show up.
All right. Well, call me anytime you want. Just call me. Let's move on to fungal. And Pedro Pascal, we keep giving you a plug, so make sure to listen.
We just mention him every episode. Maybe he'll reach out.
Maybe he will. So make sure to listen to the next season of The Last of Us when that eventually comes out. But let's start with the article, Molecular and Epidemiological Investigations of Fluconazole-Resistant Candida parapsilis, Georgia, United States, 2021, published in Open Forum ID. A bit worried here as reports of fluconazole-resistant Candida parasilosis is actually how you're supposed to pronounce that. I thought I put a little pronunciation there. Don't worry, no one's going to listen except for Pedro might. Bloodstream infections are increasing, and here these investigators describe a cluster of fluconazole-resistant Candida parasilosis bloodstream infections identified in 2021 on routine surveillance by the Georgia Emerging Infections Program in conjunction with the Centers for Disease Control and Prevention. Whole genome sequencing is performed, and the results reveal that the fluconazole-resistant isolates from the Georgia surveillance demonstrated low genetic diversity compared with susceptible isolates and their association with a facility network centered around 2 long-term acute care hospitals, suggesting clonal spread of fluconazole-resistant Candida parasilosis. So was someone not washing their hands?
I read this next one with extra interest, having had some similar patients. So NOFID, fungal foe, and mechanical hearts, a retrospective case series on Candida auris, bloodstream infection with left ventricular assist devices. So there is very little literature on Candida auris in the setting specifically of VADs, but we obviously have talked about the increasing incidence of Candida auris that I'm sure many of the audience has been experiencing and taking care of. This was a retrospective case series of 7 patients with LVAD-associated Candida auris bloodstream infection. Pretty much everything is summarized in their table 2 by these individual patients. All of the patients received micafungin as initial treatment. 6 did have concomitant multi-drug resistant bacterial infections of some kind. All died within 1 year of their initial Candida auris bloodstream infection. The time from VAD to their first candidemia episode ranged from 112 days to 2,374. Apologies, guys, I should have converted that in 2 years. But I think what's interesting, days to clear, each episode of candidemia, the mean was 21 days, but it ranged from 2 to 132 days. So you can actually look in table 2 to see the details on how many days of antifungals it took to clear, what therapies they used. I think that's what I've been struck by, is the duration of candidemia for patients in this setting, and unfortunately I suspect that this is going to come up more often as we see and identify more Candida auris And obviously it's challenging because for patients who have a VAD that's going to stay in place, you want to offer suppressive therapy, but you may not have a good oral option to do that if you're able to clear their cultures. So hopefully we'll get more info on people's experiences over the coming months.
All right, the article Clinical Course, Antifungal Susceptibility and Genomic Sequencing of Trichophyton in Dontanea was published in JAMA Dermatology. It's a case series of 11 patients in New York City, where we learned that despite being seen in a place teeming with infectious disease expertise, severe disease, ineffective standard antifungal treatments, and diagnostic delays were common. Ouch. The median range, or time from tinea onset to diagnosis, was 10 months. Sounds like we all need a primer and some education here. So we read that Trichophyton indoltinea is an emerging dermatophyte causing outbreaks of extensive tinea infections, often unresponsive to terbinafine. This species has been detected worldwide and in multiple U.S. states, yet detailed U.S. data on infections are sparse and could improve treatment practices and medical understanding of transmission. So let us do our part. In May 2023, dermatologists and public health officials reported the first 2 confirmed T. indoltinea cases in the U.S. Subsequently, a retrospective review of dermaphyte in vitro antisusceptibility testing identified this organism in several U.S. states, with the earliest confirmed isolate from 2017. Furthermore, T. indoltinea is a member of the T. mentagrophytes species complex and cannot be morphologically differentiated from other members of the complex. So, as you might assume, T. indoltinea is frequently misidentified as T. mentagrophytes or T. interdigitale. Molecular methods such as DNA sequencing are required to accurately make the identification. So, due to these challenges, the actual prevalence of this organism in the U.S. is unknown. So, I spent some time trying to figure out what went wrong, and the one point I latched on to was getting a good history. Now, when was the last time someone saw a dermatologist and was subjected to that rigorous ID history? Where were you born? Where did you grow up? Do you drink unpasteurized raw milk? Do you touch dead birds or have a dog that does? Hobbies, employment, pets, travel history. I bring this up because all but 2 patients reported travel to Bangladesh before acquiring this infection, and it looks like one of those that didn't lived in a house where they got it from someone who had traveled to Bangladesh. So I'm figuring that that last person is a spy, and they lied about their time in Bangladesh because the company said to keep that trip on the down low. Mm-hmm. Well, they share with us that data highlight that 100 milligrams or 200 milligram dosing of itraconazole for 6 to 8 weeks is the current preferred therapy, yet longer durations and higher doses may be required. There you have it.
This might be the first time you've mentioned a spy on Puzzcast, so we'll find ways to work it in. Okay. I'm slowly turning it into a Hollywood production.
Okay.
In OFID, I pulled the role of frequent screening or diagnostic testing of serum cryptococcal antigen and liver transplant recipients, a descriptive epidemiology. This was a retrospective single-center study from the University of Tokyo Hospital, which is a major liver transplant center in Japan. They ordered serum cryptococcal antigen, or I'm going to say CRAG, preoperatively at the time of transplant registry and on admission, and then twice a week post-op until discharge, as well as with any rehospitalization or clinical concern for possible crypto infection. The 1-year incidence of positive CRAG results and culture-proven cryptococcosis was 1.9% and 0.6% respectively. A median of 16 serum CRAG tests were performed in 468 patients. So of those, they identified 9 patients who had a positive serum CRAG. 4 had clinical manifestations that were consistent with infection. 2 of those were started on antifungals promptly based initially on the positive CRAG. Then 5 patients had no clinical manifestations, and 3 of those, it sounds like, remained free of any clinical changes without addition of antifungal therapy. So the authors suggested that, targeted screening may be a better approach than universal screening. I don't think that most North American centers are screening for cryptococcal antigen like this, and definitely not at this frequency. I do think that CRAG testing twice a week seems really frequent. The other thing that is interesting that in this paper, they use the cryptococcal antigen latex agglutination testing and not the lateral flow, which is what we are typically using, or at least I think what I'm used to using. Just to point out some things, that test can be a little bit more labor intensive, have the potential for more false positives. And in this case, that turnaround time on that test was 3 days. So I think interesting question. We obviously would love to catch cryptococcal infection early, and it's such an easy test to do, but I think maybe this doesn't help us figure out what's the best way to do that if we were going to screen. Perfect. And I have our parasitic section. Be sure to listen to This Week in Parasitism. This one I thought was interesting, and I think it's made its way onto the news outlets. In MMWR, outbreak of human trichinosis, Arizona, Minnesota, and South Dakota, 2022. So 6 out of 8 persons who shared a meal of black bear meat harvested in Canada developed trichinosis in, as I said, 2022. The index case was a 29-year-old hospitalized with fever, severe myalgias, periorbital edema, and eosinophilia. He actually sought care 4 times and was hospitalized twice over a 17-day period before he was diagnosed, which was eventually confirmed by Trichinella IgG testing. Upon further excellent ID history taking, I'm guessing, he and family members had shared bear meat kebabs at a family reunion. So it sounds like the meat was frozen for 45 days. I guess there was some messaging from the hunting setting where they said you can just freeze it to kill the parasites. But they tried to grill it with vegetables as kebabs. And it sounds like served it sort of inadvertently rare or undercooked, I guess, because I've never had bear meat, but it sounds like it's darker in color and more challenging to tell if it's undercooked. So sort of all the reports say, they ate it raw, but I think it was an accident and they tried to recook it. There were 2 cases of the group that were in persons who ate only the vegetables. I thought so interesting. The motile freeze-resistant Trichinella nativa larvae were identified in the remaining meat that had been frozen for, at that point, almost 4 months. So take homes, cooking game meat to at least 165 degrees Fahrenheit is necessary to kill Trichinella parasites. I think remembering the presentation, the case example is a really good sort of illness script for everyone. And then Trichinella infected meat can cross-contaminate other foods. So very interesting. It sounds like they're all doing better. So that's the good part of it. They received albendazole.
Yeah, no, it's a fascinating case, and this is an issue. And silly as it seems, Dixon Despommier and I have these discussions about: is it something about that bear tissue and the hibernation, or as it actually now looks like, Trichinella nativa actually has the ability to handle being frozen for months and months. So, yep, you gotta cook it. All right,
it's great. It's such a long time.
Pestis. Yeah, isn't that amazing? And you think, I'll just freeze it, 48 hours, I'll be good. 4 months, I should be totally good. But it's freeze resistant. All right, let's jump in with the article. Yersinia pestis can infect the Pawlowski glands. We're going to learn what those are, of human body lice and be transmitted by louse bite. Recently published in PLOS Biology. So, little background here. Yersinia pestis, the causative agent of plague, is a highly lethal vector-borne pathogen responsible for killing large portions of Europe's population during the Black Death of the Middle Ages. In the wild, Yersinia pestis cycles between fleas and rodents, occasionally spilling over into humans bitten by infectious fleas. For this reason, fleas and rats harbor them have been considered the main epidemiological drivers of previous plague pandemics. Human ectoparasites, such as the body louse, have largely been discounted due to their reputation as inefficient vectors of plague bacilli. Until now. Here we read that using a membrane feeder-adapted strain of body lice, these investigators show that the digestive tract of some body lice can become chronically infected with Yersinia pestis at bacteremia, and they give us certain levels. These lice can routinely defecate the Yersinia pestis. At higher bacteremia levels, a subset of the lice develop an infection within the Pawlowski glands. What are those? A pair of putative accessory salivary glands in the louse head. Lice that develop PG infection transmitted Yersinia pestis more consistently than those with bacteria only in the digestive tract, which makes sense, right? It's up there in the salivary glands. Now, these glands are thought to secrete lubricant onto the mouthparts, and we hypothesize that when infected, their secretions contaminate the mouthparts prior to feeding, resulting in bite-transmitted Yersinia pestis. And they have these wonderful, like sci-fi level fluorescent microscopy images, right? With M-cherry localization of the Yersinia pestis. So I do recommend going ahead and taking a look at those images. All right, I'm going to wrap us up with miscellaneous, and we just have a couple here. The first one is the article, A Meta-Analysis of Global Change Drivers and the Risk of Infectious Disease, published in Nature. This is a big data paper and behind a paywall, but very interesting conclusions. And really some interesting, if you sort of work yourself through the figures, but this is a Nature paper. So they go deeper into the weeds and comment that endpoints from pathogens with complex life cycles, such as macroparasites and vector-borne pathogens, decreased more with habitat loss of change, increased more with biodiversity change, and responded less strongly in response to introduced species compared with endpoints from parasites with simple life cycles, right? So you sort of think about it. A lot of complexity. You're not doing so well with rapid change, simple life cycle, might actually do okay. Ectoparasites increased more in response to introduced species compared with the endoparasites. They also share that this data suggests that climate change and biological invasions and loss have a part in wildlife and human diseases. All these factors also can contribute to, exacerbate, and trap people in rural poverty, which really is the strongest predictor of environmentally transmitted infectious diseases on the planet. And the last one, the article, Ventilation, Why Infectious Disease Specialists Should Care, was recently published in CMI. And the article is a discussion about our evolving understanding of how to keep our patients safe from pathogens that are borne by the air. This is a discussion of the challenges around asymptomatic, pre-symptomatic, paucisymptomatic, or atypical cases, that preventing efficient isolation, allowing pathogens to transmit in the community and inside healthcare settings. Also a call to stop using outdated terms that have been, in the words of the author, thoroughly debunked by aerosol scientists, but still used by infectious disease professionals. Here, the reference is to the droplet and airborne dichotomy, recognizing instead a continuum of particle sizes.
Great. Well, that brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, or grab it with your favorite podcatcher. We love to get your questions, comments, and paper suggestions. Send them to puscast@microbe.tv. If you like what we do or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute, or go to parasiteswithoutborders.com and click on those donate buttons.
I'm Sarah Dong. You can find me at swindong at Febrile Podcast or at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.